Hello, hello, hello. Welcome, students. Welcome from where we are streaming. There will be some lag, so can I get a thumbs up if I am visible to all and audible to all of you? Just verify whether we are live or not. Are we live? Can all of you hear me? Can all of you see me? Yeah, I will. Yes, okay. Thank you, all of you. I think we are live. Yes, Chetan Chawda. Hello. Yeah, hi. So, I think the audio video is all good and the chat box is also functioning. Thank you, all of you. I think we are live. Yes, Chetan Chawda. Hello. Yeah, hi. So, okay, yes. So welcome all of you to our FMGE preparation target 150. We will not only target 150, we'll target even more than 200. Okay, so 200 par. Okay, so we'll try to get you the maximum. Okay, no, now there will not be any echo. Okay, is there echo now? Now there should not be any echo. I've just muted it, so there should not be any echo. Yeah. Yes. Okay. So just a couple of points before we begin. All of you know the Unacademy preparation for the FMG and NEET PG preparation, and this is extremely important, the vitals. Okay, so NEET PG vitals, okay, which is complete set of pre-recorded lectures, and I request all of you, even if you can see my videos at 2x speed, and trust me, you will remember me on the day of the examination, that if you are able to see my 55-60 hours of video lectures in just 3 hours, I know it's very close to the examination, but I can vouch and guarantee you that all 30 to 35 MCQs every year, up to 40 MCQs come from this lectures in the FMG examination. And students have told me that, sir, we have cleared the FMG thanks to your OBGY lectures. Okay, and mentor, MENT or mentor is the code to get the discount. So please do not waste time, and I know we are just some days away from the exam, but still it is worth going and seeing the lectures at a very rapid pace. You will get all the marks, is my guarantee. Moving on, this is again a very important for those preparing for NEET PG, valid up to 6th of July. This is the new version of the notes along with the plus subscription, available at highly discounted price for 9 months as well as 12 months. Okay, and mentor is the code for this also. So I would like all of you to subscribe for this also. And moving on, this was a batch for available for FMG, and hundreds of learners have cleared their NEET PG and FMG thanks to the coaching. All of you are aware of the features, live lectures anytime, anywhere, notes and device of your choice. Okay, so now what is the agenda? Before that, just one more point. Tomorrow also, okay, today we are having this 5 to 6:30 p.m. session where I will be discussing all the expected likely questions for gynecology. Okay, thank you Manjula for that. Thank you. So today we are having 5 to 6:30, 1.5 hours, 90 minutes. I'll try to solve more than 20-30 MCQs for all of you. And tomorrow also we are meeting at the same time, 5 to 6:30 p.m. tomorrow also, for the obstetrics. Okay, because as you know there are two classes. So today is gynecology and tomorrow is obstetrics. So please, tomorrow also all of you do come in and do check out the sessions. Okay, the last thing, please feel free to ask questions, please feel free to answer questions, and when we ask you in the chat box, please answer in the chat box the answers, whatever you feel, right, wrong, does not matter. Okay, yes, beginning with the first question again. So there are short topics which are there, like infertility, contraception, cancers, which I have tried to cover today. Okay, best investigation for tubal patency, or to check the tubal factors. Chalo, all of you, first question for the day. Yeah, beta Manjula, we will do that tomorrow for sure. It is coming for tomorrow for sure. Manjulata, your this one Down syndrome 100% is coming in tomorrow lecture. Okay. So the important point is, please understand, Preeti Vyas is the best. Hysteroscopy wrong. Okay, A wrong. Okay. So HSG is a X-ray. HSG is a X-ray. What kind of a X-ray? X-ray with contrast. It can have lots of false positive, lots of false negative. It is the initial, it is not the best. Okay, it is a X-ray, so it is a initial investigation. It is a initial investigation or the first investigation. Is it understood to all of you? I am going to show you the HSG also. So we are going to put a dye, and with a dye there is a spill of the dye. This is the triangle uterus and this is the fallopian tube. Advantage is there is no anesthesia, there is no cut, there is no stitches, but it is the first investigation, but definitely not the best. It is not the best. Is it understood? Because finally it is a shadow. All those who are saying history, what is the second investigation? Second is a ultrasonography. Second is ultrasonography. Just give me a minute. Just give me a minute. I'll just tell. Just 1 second. Just give me 10 seconds time. After 2 o'clock, I'm not supposed to do the marks. Yes, hello, hello, hello. Okay, so anybody, can all of you, what is, yes, so what is the ultrasonography and saline? This is saline infusion sonography or ultrasonography. That is again not the best investigation. And all those who are telling me hysteroscopy, wrong. Hysteroscopy is not at all, never for tubes. What is hysteroscopy for? I will teach you today only. Hysteroscopy is to check the uterine factors, to see the cavity of the uterus. We are going to see the cavity of the uterus with the hysteroscopy. So remember students, all those who have said see, only one, Nirmala, very good. Vignesh, ab baat samajh mein aaya, very good. Nirmala correct, Vignesh correct. Okay, now so this is the answer, laparoscopy. And during laparoscopy what do we use? So please understand this, that during laparoscopy we are going to use a dye. Which is that dye? Anybody? Yes. So what is a laparoscope? We will put in a telescope. Okay, Beta Manjulata, we don't have to check trimester में tubal patency. Manjulata, the tubal patency is for a infertile patient. Once the patient conceives, why do you have to, okay, why do you have to check? So this is the investigation, tubal patency done for infertile couple. It is not which trimester. Trimester is patient is already pregnant. Very good, Snoka. Okay, Dhwani, I am coming to that. Gold standard for overall infertility. Okay, gold standard for overall infertility, it is, you can say, hysterolaparoscopy, because that gives you complete evaluation. Hysteroscopy is always only for the uterine cavity. Is it clear? It is a gold standard for uterine cavity. Okay, Dhwani, tell me yes. Very good, Snowcast. Very good, Neha Pandey. We use a methylene blue dye. That is the only place with laparoscopy. So what is done is, all of you pay attention, that this is the uterus, this is the uterosacral ligament, these are the fallopian tubes, these are the fallopian tubes. And what will happen is, and this is of course you see the ovary. So this is what, this is laparoscopy. And at the same time the assistant will take a methylene blue dye, and through the cervix the assistant will put a methylene blue dye. And what will happen? So the dye will enter through the cervix. Okay, so through the cervix this dye is poured, and the dye will enter the uterus, and the dye will come out. Blue hai pani pani, okay, blue color you will see. This is called as the spill of the dye, so with your own eyes. So don't make mistake. This is called as laparoscopy with methylene blue dye, also called as laparoscopy chromoperturbation. Is it clear to all of you? Chromo means color and perturbation means to put inside the fallopian tube. Laparoscopy chromoperturbation, but this is the best investigation. Why? Because with my own eyes I can see how the tubes are, whether the spill is coming or not, and if there is any other problem like adhesions or something, you can break the adhesions, you can check the tubal patency, you can try to correct it also. Is this understood? So but it is a surgery, it's a surgery, so it's never the first investigation. Is it clear? So HSG can be considered as an initial investigation or first investigation for tubal patency. Hysteroscopy is a very important investigation for the uterine cavity, but hysteroscopy is not for fallopian tubes. Hysteroscopy, where I use also I'll be teaching you in some time, and laparoscopy is the answer. Yes, can I get a 5 thumbs up? Then we can proceed further. Moving on to the next very important, so this is very important, laparoscopic chromoperturbation for the fallopian tube patency. Okay, yes. Now hysteroscopy is done for all of the following except anybody. So now that's why all concepts clear in one lecture only. Okay, what is hysteroscopy and where do you do hysteroscopy for? Anybody with the answer? Except is the question. Okay, except, read the question correctly. No, Rafiq Khan, no. In fact, it's very important. Very good, Vignesh. Okay, so all of you, 5 options just purposefully so that I can cover more things. So point number 1, what is a hysteroscope? So hysteroscope is an instrument which I will put through the cervix into the uterus. So we are going to see everything about the cavity of the uterus, how the cavity is. So if inside the cavity, what is this? If there is a septum, will I not be able to detect it? Yes sir, septate uterus, very important. This was also the MCQ in the recent NEET PG examination also, and last year FMGE also. Okay, for septum, what is the treatment? Okay, and what is the advantage? Hysteroscopy is not only for diagnosis, simultaneous treatment or management of many conditions it can be done. Anybody, what is Asherman syndrome? Anybody, what is Asherman syndrome? Asherman syndrome is intrauterine adhesions. This what I am drawing. Okay, intrauterine adhesions or intrauterine synechiae. Similarly, all of you, lots of conditions like a polyp, you can see this. So this is a polyp, which is endometrial polyp, or this is a submucosal fibroid. This also will cause menorrhagia. So intrauterine adhesions can be best detected and also treated. How is the treatment? I'll tell you. Menorrhagia patients also hysteroscopy we do to see whether there is any of this fibroid, polyp. Okay, this is a I'm writing SM, submucosal fibroid. Submucosal fibroid. Is it clear to all of you? Of course, all this is going to cause infertility. So infertile patients also hysteroscopy and septate uterus. Very good. What is adenomyosis? Sir, adenomyosis is presence of multiple glands. What is adenomyosis? So adenomyosis is glands, endometrial glands, but it is within the myometrium. Very good. So for adenomyosis, we are going to do ultrasonography and sometimes if required even MRI. Is this understood to all of you? Is this understood? Because when I do the hysteroscope, the cavity is normal, isn't it, students? In adenomyosis the cavity is normal. Adenomyosis is glands, this is within the myometrium. There are glands, endometrial glands within the myometrium. Is it clear to all of you? Yes. So sir, for adenomyosis there is no role. And hysteroscopy, how other way it helps? I can also treat. All of you look on the board. If I take the hysteroscope and with my scissors, see this surgery, okay, this gone, this adhesions, can you see I'm breaking the adhesions? So I can do hysteroscopic adhesiolysis, isn't it? Similarly, I can cut the polyp, hysteroscopic polypectomy done, hysteroscopic myomectomy done. And this was the question last year exam. What is the treatment for septum? What is the treatment for septate uterus? Anybody? Septate uterus, what is the treatment? I will go and but that's septate uterus, the treatment is hysteroscopically septal resection. You will go and through with the help of a scissors, you will start cutting the, you will cut the septum. Okay, that is done for hysteroscopy. Okay, so hysteroscopy, you will start cutting the septum like this, and make the septum normal. Isn't it understood to all of you? Yes. So I repeat, hysteroscopy gives me lot of information regarding the cavity of the uterus, and hysteroscopy is very useful for Asherman syndrome, infertility, menorrhagia, prolapse, all these patients. Adenomyosis, mainly the features are dysmenorrhea. They have got dysmenorrhea, severe pain. They can get menorrhagia also, but when I know it is already adenomyosis, you have to do ultrasonography or MRI. Hysteroscopy has got no role. Okay, is it clear to all of you? Septate uterus, it is a very important. Septate uterus, it is a treatment. Okay, all this is in fact treatment also, management. Okay, yes. Moving on, very important topic of PCOS. When I have the posterior wall is okay, the management or the menstrual cycle, which day to take LH and FSH levels in a case of PCOS. The management. Humble Dr. A, Snowcast D, Nirmala A, correct. Dr. Nisi A, Humble Dr. A, correct. Okay, so please understand students that we want to know the baseline level. What is the level at the beginning of the cycle? What is the level at the beginning of the cycle? And therefore those who want to become a gynecologist or a pathologist lifelong, and other students till your next or FMG exam is over, remember that FSH and LH will always be done on day 2 or day 3 of the cycle. That means whenever the cycle start, whenever the period start, that is called as day 1. Is this understood to all of you? So whenever the period starts on the first day, because as the cycle will progress, we will get a falsely elevated reading. Why? Because we want to know the baseline level. Reason nobody is going to ask you, but just mug up this, that while the patient is bleeding, because on the as the cycle will progress further, we are going to get the LH peak, we are going to get FSH will keep on rising. So if I do it on 8, 9, 10, 14 days, we will get a very high level, unnecessary high level we will get. We want to check what is the level at the beginning of the cycle. Okay, day 2, 3, 4. Okay, so this is the reason. Yes, day 2 to day 3, and that's not over. Anybody, what happens to the ratio in PCOS? In PCOS, what happens to the ratio? So what is the normal ratio of FSH to LH? FSH to LH, the normal ratio is 2:1. 2:1 is normal, and in PCOS the LH is going to be high and increasing. So this is normal, 2:1 is normal. And what happens to the ratio in PCOS? It can become ulta, 1:2 or even 1:3, or sometimes even 1:4. So remember what is asked first. If FSH LH is the denominator, LH will increase. Okay, yes. So it's called a very famous flipping of the ratio or inversion of the ratio. Is this understood to all of you? Yes. Next, so again a very important topic, Fothergill's repair. Fothergill surgery, very popular for your FMGE examination, not routinely done. It is a condition. Which condition do I do Fothergill surgery, and which complication except? Fothergill's repair is done is causing all of the following complication except. Any idea? Chalo. Where is Fothergill surgery done? A. Very good, Dhwani. Jis Alfie. Okay. Dr. Rupashri, yes. So anybody, very good. Fothergill surgery is done for patients of prolapse, but it is one of the proposed surgery for young patients of prolapse. Now please understand this. It was thought, see, in old patients I remove the uterus, hysterectomy, but in young patients of prolapse we were doing the Fothergill operation. Now can anybody tell me what is the main step of this surgery? Again an MCQ. So everything what I am asking you is an MCQ. Very good one. So the main step of Fothergill operation is cervical amputation. Please by heart, this is again an MCQ. Cervical amputation is done for which operation? Cervical amputation is done for which? 1, 2, 3, 4 surgery. You mark Fothergill operation. So cervical amputation means that you chop off the cervix, okay, and you create a new cervix. So this is a prolapse which is happening. We are going to chop the cervix. You just chop off the cervix and you create a new cervix. So what can happen, anybody, when I chop off this cervix, when I cause the cervical amputation? What is the main danger? So the main danger is that the remaining cervix which is there, sir, either it can become too tight, either it will cause cervical stenosis. The sperms cannot enter up, only patient can land up with infertility, tightly closed cervix, cervical stenosis, cervical mucus goes away, or cervix will become very loose. That's very common. What it will cause? Cervical incompetence. Please remember this, and you should know this very well. If there is cervical incompetence, it will lead to abortion. When? Anybody? It will cause, it is a cause of recurrent abortion in which trimester, all of you? Cervical incompetence causes recurrent abortion in always the second trimester. Is this understood to all of you? Very good. So yes, it can cause abortion, but not in the first trimester. It will cause abortion in the second trimester, or the cervix, because the cervix is incompetent, it will open up early, it will cause preterm. So I am giving you all the complications. Stenosis hoga to infertility also can happen. And during labor, suppose the patient conceives, during labor the cervix may not open up because of fibrosis. There would be cervical dystocia. Cervical dystocia is the condition where the uterus contracts but the cervix fails to dilate. So we can get cervical factor infertility, yes sir. We can get preterm labor, yes sir. We can get cervical dystocia, yes sir. We will not get option number 1. Is this understood to all of you? And that is the reason this Fothergill surgery, it is not at all or hardly ever done today, or not preferred, or not done for prolapse. Not done. It is not routinely done, or you should avoid it. Okay, routinely not done. because it can lead to second trimester abortion. Is this list clear to all of you? So if somebody asks you what are the, yes, first trimester, Nirmala, very good. First trimester abortions, the most common cause is the chromosomal problem is the most common cause in the first trimester. Okay, is it clear to all of you? Yes. So rest all can happen. Very good. So cervical incompetence होगा या cervical stenosis होगा, and all these are the problems with that. Okay, yes. Moving on to this, again a image based MCQ. Identify the image. Very good. What is this device, all of you? What is this famous image? Yes, A B confusion, ABC. Okay, yes. But nobody, what is the device? What is the device? The device is called as LNG, intrauterine device. Very good. Also called as LNG, intrauterine system, also called as Mirena. And very good, 52 milligram is the total LNG content. It is not the answer. The question is not the total. Very good. The question is how much is released per day. And all of you, it is also called as LNG 20, and because 20 microgram is released every day. So total 52 milligram, and every day 20 microgram is released. These are the important numbers. And for how long? We can use it up to 5 years. And very low failure. It's also extremely effective method of birth control. Is it understood to all of you? It is very effective method of birth control. Okay, can anybody tell me, very important, what are the, tell me 3 non-contraceptive uses or benefits of this device, where other than birth control this can be used. So the progesterone, because LNG is continuously released inside the uterine cavity, progesterone counteracts the estrogen and does not allow the estrogen to act at the level of the endometrium. Very good, Vignesh. So I can, and estrogen, all of you know, is causing the lining to become thickened and responsible for menorrhagia. So when I insert a Mirena in somebody's uterus, the menses, the menstrual bleeding keeps on becoming less. That's the benefit. Very good, Vani. So I can use it in patients of menorrhagia, dysfunctional uterine bleeding, even your dysmenorrhea. So those who have got adenomyosis and also endometriosis, very good. Okay, and also for endometrial hyperplasia, it can revert, and it can also prevent endometrial cancer in the long term. So it prevents endometrial cancer. That is what you need to keep in mind. And it can also used in prevention and treatment of endometrial hyperplasia. Is understood to all of you? So one slide, lots of MCQs. Mirena, total 52 milligram, 20 microgram per day, and what are the uses? Very good. Now again, a hot favorite MCQ, absolute contraindication for the use of IUCD is. There are around 4 or 5 questions related to contraception today. A, B, C, D. Very good. Snowcast, Humble Doctor, all of you, excellent. Okay, so please understand this, that whenever the fourth option is option D, student have the tendency to mark that only as the answer. No, that is not the answer. So please understand why is that ectopic pregnancy, IUCD, no connection. Please don't blame the patient's IUCD for ectopic. So when there is a past history of ectopic, no, and if she has already had 1 or 2 babies, okay, there is no contra, or even if she does not want a pregnancy, IUCD is no connection, you can use it. Nulliparous patients we avoid, but it is not an absolute contraindication. Nulliparous patients also I can use IUCD, we can use IUCD. Yes, I'm going to give you the list, very good. And acute PID is the answer. Acute PID is a absolute contraindication. Similarly, menorrhagia, yes, nulliparous patient and patients of menorrhagia we will try to avoid, but it's like a relative contraindication. So can you tell me 5? Okay, so answer is acute PID. So can anybody tell me the whole list? Can anybody tell me the whole list, at least the whole list, or main absolute contraindications for IUCD? One is of course pregnancy. Second, undiagnosed vaginal bleeding. Undiagnosed bleeding, we still don't know where the source is. Third, puerperal sepsis. Okay. Puerperal sepsis, if there is puerperal sepsis or like acute PID, then what else? No, current ectopic तो ectopic को treat करना है. Acute PID, then uterine anomaly. But a migraine with aura is for OC pill. See how you get confused in the exam. Migraine patients, why can't I put IUCD? Okay, humble doctor. Migraine with aura is an absolute contraindication for OC pills, not IUCD. Copperty का बात चल रहा. Then 2 more, following vesicular mole. Okay, when there is a vesicular mole or malignant V mole or choriocarcinoma, in that case the uterus is very soft, inserting will cause perforation and rupture. Following V mole, and what you need to tell me, distorted cavity. See, if the double cavity, 2 horns, or there is a fibroid which has distorted the cavity, okay, then again the copper T will not fit. And cervical cancer and even CA endometrial cancer I can't put. Okay, and distorted cavity. Okay, genital tuber, acute genital TB, distorted cavity. So these are 5 to 6 will remember. Pregnancy, undiagnosed vaginal bleeding, puerperal sepsis, following V mole, cervical cancer, endometrial cancer, and a distorted cavity. Very good, all of you. Yes. LH peak precedes ovulation by. We've discussed many times in the past. Those who are new, please tell me the answer. That all of us know LH peak is responsible for ovulation. So once the peak or the maximum levels of LH are reached, maximum levels, how much time will the ovulation take place? Yes. So all of you remember that from the LH surge, LH will begin, reach a maximum level. So from the onset to ovulation, entire thing is 36 hours. So if the question is about onset, then mark this as the answer. Once to reach the peak, it is going to take, peak matlab maximum levels, it is going to take 24 hours. And once the peak is reached, 12 hours, the ovulation will take place. Is this understood to all of you? Clap if you feel happy. It's a very, very important. 3 questions are discussed in the last 30 seconds. 3 numbers we will remember. 3 numbers is what we remember. 36 hours. From the entire onset to ovulation, it is 36 hours. Onset to reach the peak, it is 24, and after the peak is reached in 12 hours time, because peak पूछा है, LH peak to ovulation 12 hours. Is this understood to all of you? Yes. Moving on to the next question, one of the hot favorite, primary amenorrhea. Which of the following, some clinical cases will also be coming in some time, okay, because in case if they come in the FMG, okay, which of the following is indicating primary amenorrhea? D, B, C, E. Okay. So first of all, primary amenorrhea is a very hot topic, and the common part, of course, there is no menses. Okay, no menses, no menses, no menses, no menses. So that is there in all. Now you have to see the numbers and with certain this. Okay, so now please pay attention. Absence of menses. First you should know the old, and then I will tell you the new also. But what is the sequence? Very good, Snowcash. Thelarchy, pubarchy, menarchy. What is the meaning of this TPM? Okay, sir, in a female or in a girl, first there is development of axillary and pubic hair, development of breast, which is thelarchy, then development of axillary and pubic hair, and then the menses finally start. Okay, I repeat, TPM. TPM is the breast development, thelarchy, then pubic hair and axillary hair, and menarchy. The old, very good, the old criteria was 14 years and 16 years, which is now decreased by one year. Therefore this MCQ is surely coming. And remember always, my dear students, primary amenorrhea will have two definitions. Why primary amenorrhea will have two definitions? Because, sir, this what I told you, axillary and pubic hair and breast development is called as secondary sexual characters. So if the breast development has started and axillary and pubic hair has started, we call it that secondary sexual characters are present, and if they are not there, then I call it absent. So now common sense, all of you tell me that if secondary sexual characters are present, will we wait or no? Can I wait more? Yes, sir. Okay, sir, if T has come, if I see a girl in the OPD, breast development already started, very good, axillary pubic hair already started, then I will wait. Okay, sir, menarchy can start. Menarchy can start also in few years. So this 16 years was the old thing, and the new definition is 15 years. But 15 years if 15 years in presence of secondary sexual characters. I am writing this as SSC. Okay, SSC is the short form for secondary sexual characters. And 14 was the old definition. The new criteria is 13 years. So when I see a girl in the OPD and by the age of 13 years, by the age of 13 years, the menses do not start and there is absence. So 13 years in absence of secondary sexual characters and in presence of secondary sexual characters. So 13 and 15. So now let us see the answer. Okay, 12-year-old to hai nahi. 12-year-old is not there, because if it's a 12-year-old girl, we can wait. In this 12-year-old girl, I will wait. There is no problem. 14-year-old, those who said E, 14-year-old and no menses without breast development was the old answer 5 years back. Okay, 5 years back option E was the answer. Are all of you understanding? If there is 14-year-old but breast development has already started, I will wait, isn't it? I will wait over here because breast development has already started. So again, A is not the answer. Do you agree with me? And now between B and C. So 13-year-old again with breast development, we are going to wait, isn't it? In A and B, we will wait till 15 years, and therefore very good those who had said this. C is the answer. 13-year-old, no menses without breast development. Clap if you have learned something new. Is this understood to all of you? Yeah, Rafiq. Yeah, Siddharth. Very good. Humble Dr. Rafiq, correct. Okay, Siddharth Modi. Yeah. Okay. So that is why. That's why if you see better, see the vitals classes, you will start jumping up in there, is my guarantee. Just see it at 2x speed and you will realize what you've been missing till now. See today only, and my guarantee you will remember me on the day of the examination. Just take 1 month vitals, see the OBGY videos. In just 5 days, you will be able to finish the videos. 5 days, just see 5, 5, 6, 6 as in double, you will be finishing and you will thank me, is my guarantee. So I repeat that option A and option B both, we will wait till what thing? Sir, we will wait till 15 years. Till 15 years because sir, the breast development has started. So we will wait for them till 15 years. But option C is the answer. Okay. So just remember 13 years in absence and 15 years in presence. That is very, very important. Yeah, correct. E में breast development नहीं है. Okay, yes, karyotyping has to be done. Very good, Vani. Karyotyping. Correct, Nirmala. E में breast development नहीं है, but 14 was the old criteria. So 14 is the old. So new is 13. That's why. Okay. 14 is also primary. 14 is also definitely the criteria for the primary amenorrhea, but better answer is 13 because 14-year also is this. Correct, 14-year-old, no breast development, no menses is also primary amenorrhea, but you will make the diagnosis before. So C is much better than E as an answer. Yes, and then we should go for karyotyping. Very good. Moving on. Yes, is again a slightly new style of asking the question. CA 125 are raised in the following conditions. 1, 2, 3, 4 diya hai. That's not the answer. Yes, C is not the option, then answer is E. Very good, Snow. Okay, so select which of the condition code given below. Very good. So indirectly they are asking you that which all conditions CA 125 is elevated. A, is it only 1 and 2 only, 2 and 3, 1, 2, 3, 1, 2, 3 for all? Okay, so 4 conditions are given to you. This is just a new style of asking the question. Don't get hassled when you get such kinds of answer. So anybody? Yes, very good. CA 125 is the marker for epithelial ovarian cancer. But it is, so 1 to definitely hai. But remember students, it is very, very non-specific. CA 125 non-specific. Why is it non-specific? Because it is elevated in many conditions. So anybody apart from epithelial ovarian cancer, it is elevated in which condition? Anybody? It is elevated in endometriosis. It is also elevated in yes, very good. Any pelvic inflammatory diseases, very good. So genital TB, and even during pregnancy and menses, if the sample is collected during pregnancy, menses, and any inflammation of the abdominal organ like pancreatitis, appendicitis. Yes, and very good. Yes, okay. Pancreatitis, appendicitis, salpingitis. Okay, any appendicitis, pancreatitis, all this inflammation Colon cancer, agreed. Andrew Shaji, agreed. And therefore 1, 2, 3, 4, all. And therefore C is the answer. Basically, all of the above. Is it understood to all of you? Even if you remember these 4 conditions, which is the PID, endometriosis, TB, and epithelial cancer, and even sometimes in fibroids also, and do not forget endometriosis. Okay, is it clear to all of you? So all the conditions, and therefore option C, which is 1, 2, 3, 4, all, not this. Okay, not this, not only 1 and 2 only. Okay, yes, what is that emoji? I don't know. Nirmala, ye kya hai, Minari? Okay, yes. Moving on to the next question for all of you. Yes, CA cervix stage 3B. What is the treatment? So oncology, again a hot topic, cervical cancer. Okay, so all those who are saying A, wrong, because student को एक ही पता है कि anything cancer, Wertheim's hysterectomy. By the way, Wertheim's hysterectomy is another name for modified radical hysterectomy. Okay, modified radical hysterectomy. Is this understood to all of you? It is another name. But stage 3B of the cervical cancer means it is inoperable. It is inoperable and you will not do a surgery. Is this understood to all of you? ABC, Siddharth Modi, Abhay Veer Singh, very good. So, but let me clarify. So, ye hysterectomy, simple hysterectomy, by the way, students, is done for benign condition. What's the meaning of simple hysterectomy? Simple is not simple to perform. Simple means that only the uterus and the cervix I will remove. Only uterus and the cervix I'll remove. There's no need to remove any parametrium, lymph nodes, tube, ovary, all that. So simple hysterectomy is done for benign conditions. For your, yeah, we are coming to that. Okay, simple hysterectomy is for benign conditions like fibroid, prolapse, menorrhagia, all that. So that is anyway out. And between C and D, now tell me the answer. Very well, come back to the answer in a minute. This question came in last year's 2 years back AIMS exam. ये options आपको पता था, ये A, B, C, D. Okay. Now, next question. CA cervix stage 3B. The treatment is now given 5 options. I'm coming to the answer in a minute. Anybody? A, B, C, E. Ramesh Naidu, E. Snowcast, E. Very good, all of you. So stage 3B, of course, again means it is inoperable. We know inoperable, and so therefore B to anyway out hai, AB out hai. And please understand, students, only chemotherapy has got no role in management of CA cervix. So I am giving you a very simple table which you will remember me on the day of the examination. That, sir, when I say surgery or a modified radical hysterectomy, only stages 1A, 2, 1B and 2A. This modified radical, another name is this Wertheim's hysterectomy. So Wertheim's hysterectomy is for which 3 stages? All of you repeat after me. Repeat after me. 1A2, 1B and 2A. That's it. Understood this, students? 1A2, 1B, 2A. Only these 3 stages I can think of. I'm writing WH. WH is a Wertham's hysterectomy. Wertham's is the name of a person. Beyond this stages 2B, 2B, 3, 3A, 3B and 4A, 4B, all 3B जो question है, they are inoperable and treated only with radiotherapy, and therefore in this MCQ radiotherapy is the answer. Is this understood to all of you? Because the question asked is stage 3B. Please by heart the stage wise treatment. Simple hysterectomy I told you is only for benign condition. Chemotherapy has got no role. So radiotherapy is the best answer to mark among these options. But remember students that most of the time before I give radiotherapy, can something be added to improve the effectiveness of this radiotherapy? Yes sir, cisplatin. Very good Rafiq Khan. Cisplatin is added, or this radiotherapy is both. Okay, what सीधा brachy, you can give दूर से teletherapy and अंदर से brachytherapy, but cisplatin is added first day and the remaining days radiotherapy is given. So therefore the newer word used is CTRT, or you call it as concurrent chemoradiation. Concurrent chemoradiation. So if concurrent chemoradiation or CTRT is in the option, it is a better answer to mark compared to RT, and therefore this MCQ, yes, RT is the answer. Only CT is wrong. Only CT wrong. But now when I have to choose between RT and CTRT, can anybody tell me what is the better answer now between this option D and E? Yes sir, now the answer is excellent, all of you. CTRT better. CTRT better than only RT, and therefore now CTRT is the answer. That's why students tell me that sir, so many books we are reading, study guide, one time this is given, one time this is given. You don't know, because all these concepts till the time you listen to the lectures, you will not get all these answers correct. So stage 3B sir is inoperable, hysterectomy is out, only chemotherapy is out, and RT and CTRT दोनों option में है, तो I will choose CTRT only, and therefore here also CTRT or concurrent chemo radiation. Is this understood to all of you? Concurrent chemo radiation, and therefore that is the answer. Okay, and if this option, when CT and RT are separately given, then of course RT becomes the answer. Okay student? Yes, very good. So 2 question discussion. I hope this is crystal clear. Please by heart this, you will remember me on the day of the examination is my guarantee. Okay, yes. Moving on. Again a very simple, always asked, primary amenorrhea. Primary amenorrhea patient. USG, uterus not seen. So can anybody tell me, if the uterus is not seen, CD, which one to go for? C and D. So all of you, why are you making this mistake? Yes, option C nahi. So now anybody, can anybody know what are the only 2 options? Why is option A and option B out? Option A and option B ruled out. Yes, sir, option A, Turner syndrome. The uterus is present. It's a small hypoplastic underdeveloped uterus. But remember students, Turner syndrome is never absent uterus. absent uterus is not there. I'm putting a cross here. Clearly they have told you ultrasonography, uterus not seen, that means uterus is absent. Okay, so dear students, when there is a combination of primary amenorrhea plus absent uterus, this MCQ comes every year in the entrance exam. This has to come. There are only two options. One is RMKH, which is Rokitansky-Meyer-Kirschner-Hauser syndrome, also called as Mullerian agenesis, and second is androgen insensitivity syndrome, complete androgen insensitivity syndrome or androgen insensitivity syndrome. Okay, yes, very good Dhwani, very good Rupashri, very good Andrew Shaji. Okay, very good ABC, Preeti, all of you. So how do you differentiate that here? The important, तो ये दो ही option है whenever you get primary amenorrhea absent uterus. So option 1, option 2 out. Turner syndrome, uterus is present. And look at, breast is well developed in both of them. That is not a difference. When you see the patient, when you will examine the girl, the breast development, I'm writing over here, breast development, here also tick tick, here also tick tick. Breast development is there in both. But what is the important point, sir? When I look at the axillary and pubic hair, when I look at the axillary and pubic hair, remember students, even in females, the axillary and pubic hair is androgen dependent. So RMKH is a girl which is normally functioning testosterone, and axillary and pubic hair is well developed, and here axillary and pubic hair is absent because it is androgen insensitivity. The testosterone cannot act. The testosterone is useless. It's like nikamma testosterone. Testosterone is present but it cannot act. So clearly now look at the question, breast development present but axillary and pubic hair absent. This is your clue, and therefore the answer is not option C, it is option D. Is this clear to all of you? Yes, receptors for testosterone insensitive. Rather than no receptors, it is the insensitive. Very good. Okay, so androgen insensitivity syndrome, here the axillary and pubic hair is absent. This MCQ surely comes, and if the same question they tell you axillary pubic hair is present, then only you have to go. Here it is present. What is present? This axillary and pubic hair. Is this understood to all of you? So please don't make a mistake in this MCQ. Surely this type of MCQs are coming in the exam. Yes, come on, what is the diagnosis? Okay, infertility, dyspareunia, dysmenorrhea, retroverted fixed uterus, fixed matlab because of adhesions, with nodularity in the pouch of Douglas. I want the diagnosis first. Very good, Sushmita. Siddharth Modi, क्या हो गया? Why are you crying? Not to worry. Yes. So, no, not A. Okay, what is the diagnosis first? This is endometriosis. Very, very important. Why endometriosis? Because all of you students, please read what is the classic triad of the features. DID, dance, India dance. All this I teach in my actual classes. Okay. DID, dance, India dance, matlab D stands for dyspareunia, I stands for infertility, and D stands for dysmenorrhea. So whenever I have a triad of DID, think of endometriosis, infertility, dyspareunia, dysmenorrhea, and along with fixed uterus and nodularity in the pouch of Douglas, the history is highly suggestive of endometriosis. Yes, sonography may detect only which part of endometriosis? Sonography will only see the chocolate cyst and nothing else. Only the chocolate cyst we will see, rest all the endometriosis will not be seen. Again, those who said HSG, no point, HSG is for tubes. Yes, tubes may be blocked, but will not see, do not detect endometriosis. And hysteroscopy, no role. I told you what is endometriosis. Sir, endometriosis is presence of endometrial glands outside the uterus. All the endometrial glands and everything is outside the uterus. These are all the endometriotic spots outside the uterus. So when I do hysteroscopy, sorry sir, hysteroscopy is only, I showed you to see the cavity of the uterus. Here cavity is going to be normal, uterine cavity normal. So what is the point of doing a hysteroscopy? No point. Yes, the growth is outside the uterus. And how does this growth look like? Anybody? What is it going to, how is it going to help us? And sir, what will help us? Sir, when I do laparoscopy. Laparoscopy is putting in a telescope through the abdominal wall to see the pelvis. I will see the uterus, I will see the fallopian tube, I will see the ovary. And what all do I see in endometriosis? Anybody? Point, give me 5 features. What are at least 5 findings what you get in endometriosis? Khoon ke kitne rang? What all? Very good. Sir, I will see blueberry lesions. We can see blue lesions, blue color lesions we will see. We will see purple color lesions. Very, it's a colorful picture. Blueberry, red raspberry, purple raspberry, chocolate cyst. Very good. And I can also simultaneously treat it. Okay. Yes, gunshot. Excellent. So brown color. Assume this is brown color. Okay. Yes, this look like brown. Okay. Brown color chocolate cyst also you will see. Very good. And there will be adhesions. There could be adhesions between the tube and the ovary. And 2 more color lesions, red color. Very good. Red raspberry. So all these are seen in the pouch of Douglas. Red raspberry, purple raspberry, blue raspberry. And lastly, somebody said matchstick burn spots. Very good. Matchstick burn spots or gunshot appearance, those are the black color spots. Okay, so this picture lifelong you will remember is my guarantee. And to see all this, I have to see with my own eyes. And laparoscopy is the investigation as well as simultaneously it helps me in management also. Okay, is this understood? So there could be adhesions between the tube and the ovary. There will be all this gunshot, matchstick burn spot, powder burn spots, which I have to do with laparoscopy only, because everything is in the pelvis. In endometriosis, I have to see the pelvis of the patient and not the cavity. Yes, moving on to the next question. Again, hot favorite. MTP, new role. All of you should know this. Very simple. Yes, very important. Please don't make a mistake in this, that sir, MTP was allowed till 20 weeks of gestation, but now for certain conditions, which condition we can now, because certain anomalies are detected late in the baby. So for anomalies which are detected between say 20 to 23 weeks, or in special circumstances where it's a rape victim, victim of sexual assault, or they undergo divorce late in pregnancy, all these cases now MTP is up to 24 weeks of gestation, but between 20 to 24 2 doctors have to certify. Okay, so certain anomalies could be detected late in the baby, and if mother is at risk or it is a a pregnancy is because of rape or sexual assault, then we can do MTP till 24 weeks. 20 weeks is still for failure of contraception. Failure of contraception is still only till 20 weeks. Don't make a mistake in this. But overall, for anomalies and special situation, as they call it, special cases, we can do till 24 weeks of pregnancy. Okay, this change happened in 2021. Likelihood that the question will come over here. Again, a sure shot MCQ, PYQ, previous year question. Decubitus ulcer. No beta, fetal anomalies, there is a limit of 24 weeks, but no limit is when mother's life is at risk. Okay, माँ और बच्चे में से माँ को बचाना है. Mother is more important. Okay, Rafiq. So when the mother's life is in danger, then there is no limit. Then you anyway have to terminate. Like there is eclampsia, then you have to deliver the patient. Okay, Rafiq. Anomalies, there is a limit for 24. Beyond 24, then you have to go for court case, and only if court gives permission, all that stuff. Okay. Yes. What is the decubitus ulcer and why do we get it? Where do we get it? No, 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 no. Yes. Very good. Tamalika Das, Shubhadeep, Nirmala, Jis, Alfie. Very good, Andrews. Okay, so decubitus ulcer is the ulcer which I will see in the prolapsed part. If this is the prolapse, it's a circumferential ulcer around the cervix. Around the cervix, the part around the cervix, we get the skin gets eroded, and there is a circumferential ulcer which is seen mainly in 3rd and 4th degree prolapse. Why do we get it? The old theory was, sir, it is because of friction between the thighs. The new concept is it is because of vascular congestion. And what is the treatment? Sir, you will take a bowl. In the bowl, so this is like your NEXT exam where they will ask you practical topics. If you have gone to the ward, you will be able to answer. In the ward, there is glycerin and acryflavine, and you will take a tampon. You will take a tampon which is dipped with glycerin and acryflavine. Acryflavine is what and glycerin is for what? You don't do laser excision, you don't do packing with H2O2 and acetic acid, no, and you don't do cryo. Okay, glycerin is what? Sir, glycerin is a hygroscopic agent. Glycerin is a hygroscopic agent. It is going to decrease the edema. And acryflavine is a yellow color liquid or a yellow color dye. It's a yellow color dye which will help in the, which is with antiseptic property. Yes, which will help in the reepithelization of the ulcer. Okay, it will help in reepithelization of the ulcer, which is going to help in healing of the ulcer. So you are supposed to take a tampon which is dipped with this, and that tampon we just push it inside. So that is the answer. Okay, that is the answer that you have to pack with the glycerin acryflavine dye. Now identify this image. Identify the image, and if you see, this is what are we seeing? Yes, so all of us know, sir, this is the speculum ka border, and this we are seeing the cervix. This is the anterior lip, this is the posterior lip, this is the cervical opening. So we are seeing the cervix. But can anybody look at the color? The whole thing is looking green in color. Why is the whole thing green? Because sir, this is nothing but a green filter used. Okay, so this is not a pap test being done, green filter. See, like Hulk, the whole picture is having a greenish color. Okay, so this is the anterior lip of the cervix, the posterior lip, the cervical opening. And the purpose, what is the purpose of, yes, this is colposcopy with a green filter, and green filter is used to see the blood vessels. Okay, blood vessels are seen best with green filter. So this is of course a virgin MCQ, this has never been asked, but only thing 2-3 years back FMGE, this was the, yeah, acetic acid beta you apply, acetic acid you apply. Baljinder, A nahi hai, this is not hysteroscopy. Hysteroscopy we are seeing the cavity of the uterus, ye abhi hum bahar pe hi hai. Okay, acetic acid is applied and then you take the biopsy from the acetobite area and then you see the green filter. Green filter mein, why is this important? Because question had come last year that in colposcopy to see blood vessel which color is used, blue, green, red, yellow. So green filter just means the green light. You just see the whole cell through green light because there are blood vessels, then blood vessels are seen very well. Okay, blood vessel will give you a punctate pattern. Okay, punctations. So blood vessels are seen very well. Because why I want to see blood vessels? Because there's any cancer, the feature is neovascularization. And neovascularization is best seen with green color light. As physics principle, forget the details. But when there are red color blood vessels, if I see with green color, they are seen much more basic easily. And the blood vessel will be seen like a punctate pattern. You will see punctations and you will see the blood vessels. Okay, so abnormal vasculature. So this is colposcopy being done with a green filter. Yeah, no problem. Yes, very good, Balji. Okay, so that is again very important. Okay, clinical case, very simple with all the discussed today only. A 27-year-old married lady comes to us for treatment of acne. She's got acne, hirsutism, irregular periods, LH level 15, FSH 5. We know what is the answer. What is the diagnosis? What is the diagnosis? Very good. PCOS is the diagnosis. But all of you please pay attention. Those who are saying Ramesh Naidu D, wrong. Jis Alfie D, wrong. Because please understand, D is for ovulation induction. When she wants treatment with infertility, when she is planning a pregnancy. Is this written over here? Does she want pregnancy? No. She has come to us with what? So she has come to us with treatment of acne and hirsutism. Please clearly all of you read what is the question. Sir, the question is yes. So she has comes to us for treatment of acne and hirsutism. Will letrozole help in acne hirsutism? Never. Will clomiphene help in acne hirsutism? Never. So PCOS, when there is infertility, or when they are planning a baby, when they want a baby, that is the time only you will use letrozole or clomiphene citrate when they want baby or when they are planning for pregnancy. Is this understood to all of you? But when they want treatment for acne, hirsutism and irregular periods, the best is OC pills, isn't it? All of you. Thoko Talif, those who are not heard me before and hearing me for the first time, नाम में ही आंसर है PCO, उल्टा कर दो OCP. ठोको ताली. That means polycystic ovary, oral contraceptive pills, OCP. PCO, OCP. Nobody will teach you like this, is my guarantee. So I have to go for OC pills and I have to choose between A and C, and C is the answer. Why? What is the speciality of cyproteron? We can use a OC pill with cyproteron or drosperinone. Okay, because LNG will slightly increase the acne. LNG will slightly increase the acne. Okay, LNG will slightly increase the acne, so I avoided drosperinone and cyproteron. They both are progesterones with a anti-androgenic property. Thokotali. Okay, so anti-androgen property. Very good, Navina, and all of you. Yes, so I would like to give her OC pills, which is having OC pills will suppress the androgen, anti-androgenic. They will make the cycles regular, and they will decrease the acne, decrease the hirsutism. Is this understood? So diagnosis simple, but letrozole is a drug of choice for when I want to go for ovulation induction. Okay, Nirmala, drug of choice letrozole for ovulation induction, for pregnancy, not when they are planning, not when they want treatment for acne and hirsutism. Okay, so to see what is the patient's wanting. Yes, again famous MCQ. Recently married, so newly married, healthy couple, newly married for 1 month, both partners are healthy. Healthy means no smoking, no heart disease, no blood pressure, no diabetes, all contraindication ruled out. Pregnancy they want to delay at least for a year. What will you advise them? Very good. So here, sir, vasectomy is out of question. Vasectomy is a permanent method. I am thankful nobody is marking that as an answer. Similarly, IUCD, she is just married, so she is nulliparous. So in a nulliparous, it is not that I cannot use IUCD, but better to avoid if you can avoid it, and they want only for 1 year. 2, 3, 4 years hai to okay. And condoms definitely decrease the sexual pleasure, and along with that high failure rate. So you have to give them something which is reverse, which is for very effective and also short term, like 1 year. So they can go with, or she should go with OC pills, which is absolutely the best answer. This is what I do every day. There's no confusion. The Love Pandey condom A will decrease high failure rate. Okay, so 14%, 4 to 14%. So we should not use condoms. Are not for married couples because the failure rate is very high, and they also decrease the sexual pleasure. Condoms are good for STD prevention. Okay, and the couple is healthy. That's the clue given to you, that they don't have migraine headaches, they don't have hypertension, diabetes, all the contraindications are ruled out. So this is what we do every day. Newly married healthy couple comes to me, we give them OC pills only. Okay, so don't make a mistake in this. Yes, we will very quickly go with this because we've already discussed. Again, we have got web neck. What is this? Pediatric, shield shaped chest, widely spaced nipples, and streak ovaries. So this is giving away the answer. Nothing much to discuss in this. We will not waste time, but this is an important MCQ. Uterus will be present. It will be smaller in size, but rest all features: primary amenorrhea and streak ovaries and web neck. Okay, MRKH and CAIS, I repeat, both will have well developed breast. They will not have shield shaped chest. Thank you, Dr. Buddha. Love you for the comment. And 20 for congratulations. Superb. Congratulations. You will clear any extra exam also. with flying colors, and NEET PG also my guarantee. Okay, great, good to know that. Congratulations. Yes. So and students tell me that, sir, we really what do you call hear your voice in uh, hear your voice in the exam and we are able to answer. Yeah, thank you. Okay, yes. So very we'll come back to this in a minute. uh, yes, can anybody tell me this? Arrange the sequence of events when we are doing a dilatation and a curettage. Yeah, when we are doing a dilatation, again this is one of the PYQs. What is the sequence of events? What are we supposed to do? Yes, so first we are supposed to do a PV examination to determine the size and even the position of the uterus, whether uterus is anteverted or uterus is retroverted, how big, how small. So determining the size of the uterus, we would definitely now go to number 4 as first. So this is out. Okay, very good. Then what do I do? Always remember, we are supposed to sound the uterus. Sound will again determine what? Sound will determine the uterocervical length. Uterocervical length it will determine, and it also acts as the first dilator. Is this understood to all of you? So after I determine the size of the uterus, we are going to do the uterine sounding, and then I will dilate the cervix, which is with the serial dilator. Which dilator? They are called as Hagar's dilator. And then finally we are going to do the curettage. So absolutely correct. 4 1 2 3, 4 1 2 3. PV examination, then sounding the uterus, then dilatation, and then curettage. So this is there. DNC is done for menorrhagia and for detecting the endometrial hyperplasia malignancy, all these cases. Okay, commonest cause of primary amenorrhea without wasting any further time: ovarian dysgenesis or your Turner's syndrome. Turner's syndrome is 45XO. This is the most common cause of primary amenorrhea. Your RMKH is the second most common cause. Okay, androgen insensitivity, third most common cause. Okay, so please keep this in mind. This is very simple and very important. Yes, anybody? MTP at 45 days. Again, a total confusion among most of the students. So this question we have selected, very likely to be coming in the exam. Yes, so please don't get confused. Always remember, again I will give you a tip and trick to remember. There are two drugs, mifepristone and misoprostol. Which is given first? Remember, in alphabetical order you can remember that, sir, MI is same, but F comes before S. So sir, mifepristone is given on day 1, and after 48 hours on day 3 this is given. Okay, is this clear to all of you? So you don't give option B first, option B out, because उसमें meso दिया है first and mifi after 48 hours, so option B out. Similarly, option D also out, because in this also meso is given first and mifi, so this is wrong. I have to choose between only A and C. And why is option A wrong? Because the dose mifepristone is not 200 microgram and meso is not 800 milligram. The units have been exchanged and therefore option A is wrong. What is the exact thing? Sir, mifepristone is a single tablet which is given single tablet of 200 milligrams on the first day. By the way, this can be done up to 9 weeks or 63 days. Okay, 9 sevens are 63, 60 days. Okay, so that is the mifepristone which is given up to 200 milligram, and after 48 hours, there are 4 tablets of meso. Each tablet is 200 microgram mcg. Don't make a mistake. So you get totally 800 micrograms. 800 microgram, that is what it is after 48 hours. Okay, so that is 200 milligram followed by 800 microgram. This is technically put in the vagina. This is the oral route. Okay, so mifi is always given orally. Meso can be put vaginally. Vaginally we can put it, or we can give it sublingual or even oral. Okay, is that clear to all of you? Yes, so option C is the perfect answer. Mifepristone 200 milligram and misoprostol 800 microgram after 48 hours. Moving on, yes, again this was the PYQ. Very simple. What is this? Identify the hysterosalpingography image, HSG. I'm telling you it is HSG. Now what do you see? You have seen the previous one. Yes, very good. Sir, normally the uterus is triangle. We see a triangle cavity and we see both the fallopian tubes and we see the spill. HSG is best done on day 9 or day 10. Okay, around 8 to 10 days we can do it, which is the HSG done. So triangle. But here what we are seeing, we are only seeing one side of the uterus, isn't it? Only one side of a uterus. Very good. Like, and also deviated to one side, and one side fallopian tube is also seen. So this is called as a banana shaped uterus, and it is a sign of unicornuate uterus. It is not a normal HSG, and Asherman would give rise to okay. Yes, very good. Travel with Chandan, very good. This name of the cannula could also be asked to you. With what we do, it is called as Leach-Wilkinson cannula. Leach-Wilkinson cannula, or also called as Colvin's cannula. Okay, and can anybody tell me what is this? Identify this. Okay. So 2 HSG mein this is clear cut unicornuate uterus, deviated to one side and a banana shape. Now whenever we have got 2 horn, this is your radial, please pay attention. The septate uterus, all of you pay attention, lifelong you will not make a mistake. So septum is within the cavity. Septum is within the cavity. So this part will not get opacified. Do you agree with me or not? This much part will not get, because septum is projecting inside. So suppose my dye, I know the dye is white in color, but let me just for simplicity put here the dye. So suppose the dye is like this yellow color picture. What are we going to see? Sir, we are going to see 2 horns. We are going to see in HSG 2 horns which are very closely together. Can you see this, both the two horns? And therefore what is the angle going to be between them? Very very important, don't make a mistake. When I see this and when I see this, this angle is going to be a acute angle, that is septate uterus. But what is, okay, what is, better Dr. Siddharth, please focus on the studies. Okay, yes, this one. And what is the bicornuate? Sir, bicornuate, there are two horns which are widely apart, one horn is like this, another horn is like this. So when I will measure the angle between the two horns, what is the angle going to be? Anybody? So the angle is going to be a obtuse angle. Is this understood to all of you? Yes. So please understand, yes, it is difficult on HSG, but this, I would say, this is a acute angle for sure. This is a acute angle for sure, and therefore we will go with septate uterus rather than not unicornuate and not bicornuate. Is this understood to all of you? So I repeat, when it is a acute angle between the two horns, mark it as septate uterus, and when it is a wide apart obtuse angle, then it is a bicornuate uterus. So I hope all of you had a great time today. Thank you very much for coming in today, and do not miss, you can leave your words and appreciation in the chat box. Thank you all for coming in. This very all the high for gynecology, and I see you again tomorrow at the same time, 5 p.m. for a fabulous things on obstetric. Yes, all the double marker, triple marker, which trimester what to do, all the clinical cases, eclampsia pregnant, all these cases we will be beta vitals, if you see, is of course very good, because vital will help you see lots of other MCQs also, because there are totally around 56 chapters. So see it at double plex. So I am tried my best to see the 12 hours and this as a to complete majority courses. Okay, yeah, okay, so that is how. And tomorrow 5 p.m. we will again meet for the obstetric lectures. So thank you very much for coming in today, and I will see you tomorrow again for obstetric MCQs on the same channel YouTube. Bye bye, best of luck, thank you very much.